Good? All right. So what I was hoping to do with you guys today, and if you need to get closer, you can come and look, but you all have that handout that shows the checklist. You can't hear me?
By this thing, I think.
Okay, it's okay. So that checklist is what I use to train the residents and the med students before they're supposed to do that before they have their rotations in either the MICU or the SICU. So I'm going to try to go through that list, and if I make some mistakes, I want you guys to call me out on it. Some of the things that I'm going to go over are the equipment, what's in the kits, what they need to get extra, what you need to do to help them in those situations, and as we go through it, just sort of make a mental note about how we're doing according to that checklist. So I'm going to talk to you about things like bundles. You guys know what a bundle is? Heard the term bundle? Yes? So a bundle is a grouping of training, equipment, policies that all go together to make a better patient outcome. There's something sticking out.
Watch your head.
I wasn't part of the group that came up with this curriculum, but a group of physicians and nurses worked together for about 6 months to come up with this particular curriculum. It's not totally inclusive. The only thing we're going to talk about today is subclavian line insertion. I'm not going to talk to you about IJs or femorals or any other kind of line. I'm not going to talk about ultrasound, even though a lot of people are using ultrasound now, because that's an additional skill. What I'm going to try to demonstrate for you is a subclavian line based on the best practice that was come up with in terms of how our hospital wants to do this. And all hospitals have their own way of wanting to do that. So to start with, let's talk about, as you know, let's talk about what we consider to be the clean area. Right now we're over in the PSCU, and so we don't have the red lines that are in the rooms, right? In all of the patient rooms, there's a red line inside the door. If you look on the floor.
Patients who are in isolation have that.
Only on isolation.
Yeah.
Okay. So where that line would be for isolation, if you're beyond that line and you're in the room that's going to have a central line, you need to have a cap on and a mask on. So anybody who enters the room needs to have that. So your job, one of your jobs is to make sure that if you're the nurse that's helping with that procedure, that anybody that comes in, make sure that they know that they need to do that. In these rooms, it's inside the curtain that we're talking about. So, you know, this is a little bit bigger than some of the areas in the pit, but if you're inside the curtain, you need to have this and this on. Okay. The other key component of the first few steps is that everybody's going to use best hand hygiene. And that means that you're going to foam in and out of the room. You're going to clean if you have any C. diff patients or your hands are dirty. You know that they're dirty. So, you know, I foamed into the room. Now I'm checking out with the patient. Let's just, for this case, we'll say that this patient is intubated and sedated. But the first thing that I'm going to do is talk to whoever the nurse is that I'm working with. So this is Mr. Smith, and we need to do a central line on Mr. Smith. Did we give that information sheet to the family about why we want to do a central line?
Sure.
Yeah?
Did we?
So there's an information sheet that's in the PRISM Navigator. It's called Patient Information. And in that, it's a standard handout that's used by multiple national organizations that explains why we do central lines and what the risks and benefits are to central lines. In the PRISM Navigator, it says consent obtained. And if you look at the wording that's right next to it, basically it says that that information was given to either the patient or their family. And that's what we consider consent. It's not a signed consent form. It's that they were given that information. It's from the International Society for Infectious Disease and the Joint Commission all came together to make this up. And so sometimes that may be your responsibility, or you may be able to do that. Say, yeah, I gave that information sheet to the family already. And that's all inside the Navigator. Then next thing I'm going to do is make sure, you know, Mr. Smith needs I'm going to do a right subclavian. It's okay if I do a triple lumen, 20 French, or 20 centimeter line. Is that okay with you?
Sure.
I like to check with whoever the nurse is to make sure that I use the right number of lumens. Make sure that they know what I plan to put in and where I plan to put it in. It does two things. If the patient has a condition that maybe I'm not aware of, especially true if it's say it's somebody who's covering the unit, they're new to the service, or in other ways, they're just coming in to do this procedure. They don't know the patient all that well. You may know something about the patient, like, are you sure you want to do that? They have a right clavicle fracture. You want to put a subclavian in a right clavicle fracture? Probably not. So those are the sorts of things that you want to make sure that you talk about. Once I do that, I start to put my patient in the Trendelenburg position. I start positioning the patient. So I have them with their head turned to the side. So if I need respiratory, to make sure that their tube is well secure, the vent's all set up. I'm going to do that. For me, this is about the right height. Now you may not be able to see all that well, so you need to make sure that you can see what I'm doing, or we can work together so that you can see what I'm doing. I can see where you are, sort of thing. I'm going to get a side table. Side tables, these are the most common types. We also have some places have Mayo stands, especially like in the operating room. This kit has a drape in it that's big enough to cover a standard side table. Used to be that you had to get a drape out and then drape your side table and then put your kit on top of it. These kits are made so that they have the drape that's big enough to cover that table. I need to get my sterile gloves, my gown, and then I need to be ready to prep the patient too. So the prep, we only are going to use chlorhexidine and alcohol, or chloroprep. They come in those nice little breakable devices. There's 3 different sizes that are common. We have in the cart, that's the central line cart over there, the central line cart just has the 3 cc's. In order to clean this area well, you need at least 10 cc's, so you need at least 3 of those to do that. Vaughn has some 10 and some 30 cc chloropreps that are sometimes easier, but they're a lot more expensive, so we tend to just leave the 3 cc preps in there. When you prep, it depends on how you do it, but essentially once I'm done at least a timeout saying, Mr. Smith, right subclavian, this is a 7 French triple lumen, 20 centimeter line. Sound good? Okay. So that's the first timeout that I do. I like to do a second timeout, which I'll show you in a little bit. Now I'm going to start to make sure that I have all my equipment together. All of these kits come with flushes, sterile flushes on the back of them. So before I open the kit up and get myself ready, I'm going to open up, this is just a Ziploc baggie. I'm going to give those flushes to my helper and say, can you give those to me when I'm ready? Mm-hmm. Great. I'm going to get, for the terms of the video, I'm going to do my gown and gloving right here. But normally you'd want to have a separate area. I usually use the silver carts in the room. That's about the height of my waist to set up my gown and my gloves. And I'll get those things ready to go. I like to prep the patient before I gown and glove and do everything else, just because it's important. One of the things that your checklist says is that the area is completely dry before you start the procedure. And you've probably seen this before, at least I see it in the OR all the time, is we come in, we've got our gown and gloves on, and we go over and we prep the patient, and then somebody grabs a towel and pats it dry. The way that the antisepsis works is through friction and desiccation. It means that you scrub hard enough and then you let it dry long enough to kill all the bacteria on it. When I first went to school, you used to have to start in a circle, start where you're going to go and work your way out. The evidence shows that that is not the right way to do it. If you don't often apply enough friction and you don't clean the area well enough by doing that. The better way to do it is to scrub. So I like to scrub and then let it dry while I'm getting everything else set up. Because all my other materials that I need, I know from my bundle that they're going to be in here. There's nothing else that I really need. Okay? So I'm not going to clean this mannequin. If I use the chloroprep on it, it destroys the mannequin. So I'm not going to do that. But if you can imagine, I'm going to put on some gloves. I'm going to grab my chloropreps. And I'm going to clean widely. It's important that what I train the residents to do is I have them start at the mastoid process, so at the back of the ear, come over to the jaw, down midline, just above the nipple line, excuse me, below the clavicle, but above the nipple, out to the AC joint and then connect that back up, it makes a nice frame. Then they fill in the frame with enough of the prep. It's colored, so they should be able to see exactly where they've colored the area. And then they scrub. Once they've colored the whole area, and then that's when the scrubbing starts. The subclavian area is considered to be a dry location versus a wet location. Wet locations need to be cleaned for a longer period of time. So if they're doing an IJ, they need to clean for a minimum of 1 minute. They need to let it dry for a minimum of 1 minute. If it's a dry area, it's a minimum of 30 seconds. You should still let it dry about a minute for it to work. So the amount of time that they clean, the amount of time they let it dry can vary. Femoral, which we don't do a lot of, but when we do them, that's a very dirty area. It's a wet area. You have to clean that really well. In the femoral area, especially with people with a higher BMI, I'll actually use the 30 cc prep and really clean the heck out of it, tape the pannus up if I need to. Okay? So, so imagine that we've prepped this patient out now. So now I'm going to get all my stuff ready. First thing I'm going to do is open my kit up. Now, when I first learned how to do this, I would walk in the room and say, hey, I'm going to do central line, and the nurse would go, great, I'm going to take a break now. Nowadays, you guys should stay in the room. That's the standard. That's what our policy states, that there'll be somebody there to help. Old habits die hard, though, so I'm used to doing this by myself. Inside this kit, if I open this kit up, I know basically what to expect in it. Here's another prep. This is meant to be for the end. If I was already gowned and gloved, I could do this also, but I know that I'm not going to use this stuff until the end, so I'm just going to set it over there. The way to use this, well, before I'm all clean, is I have to open it from the ends. So I'm going to flip this drape like that, and I'm going to come over to the other side and grab the edges and flip it like that. What I don't want to do is reach over this, because I'm not sterile. If I reach over this, technically, that's not a sterile area anymore. So that's one of the things that you should be watching for, is not, just willy-nilly opening this kit up. So this is basically ready to drape this patient out. So I'm going to get my gown and gloves ready now. I'm going to show you right here. There's two types of gloving techniques that people commonly use. When you're gowning and gloving yourself, you should be using what's called a closed glove technique. Normally I wouldn't do this right on the patient, but imagine that I want people to be able to see what I'm doing. I'm going to open up my gloves so that I'm ready. I'm going to clean my hands one more time before I gown, even though I've, foamed in and out of the room. And you're going to have to help me. So all of the gowns at Fletcher Allen that we use are going to have this purple stripe on it. That's the neck line. Essentially, it's a half moon, and it should be facing. I should be grabbing the gown like this, and finding an area where I can put the gown on that's away from everything else. I'm not going to bang into anything. So I'm going to come over here. I use my foot to sort of move things out of the way. All right, so I'll have you go ahead and put my Velcro and my back tie on now. Inside my right side.
I get to see.
Nope. So this gown is defective. Do you guys see that it's defective? What she tried to hand me was the purple and white tab. That tab should be connected at my waistline. When I opened this gown up, it was disconnected. So technically, we should be starting over with a new gown. Okay. Inside my right side is the tie. You got that tie?
Yeah.
Okay. Good. You can just leave that hanging. So what I'm going to do now, I have my hands inside the sleeves. What I'm trying to do is keep my hands from coming out of the white cuff. This is part of the closed glove technique. I'm a righty, so I'm going to grab my right glove first. I'm going to make sure that when I do that, I'm over a clean area or sterile area. I'm not banging into anything that I shouldn't be. To put this glove on, I'm going to take my thumb in my cuff. I'm going to put my thumb on the thumb of the glove. The fingers are going to face towards me. And I'm going to then take the other side of the cuff and flip it over like that. You can see that my fingers never come out of the gown until I'm inside the glove. I know that with a large or an extra large gown, that if I just pull on my sleeve like I'm doing right now, my fingers will go into the right area. The white part has never come beyond the edge of the cuff. Now I can pick up my other glove. Same thing. Basically my palm is up. I'm going to find this cuff, flip it over just like that, and then slide this sleeve down. And my fingers will go right in there. Now is the point where I should spin. So normally I'd have, if this gown weren't effective, I would grab that little purple and white tab and I'd hold on to this tab with my hand. I'd hand that to you and I'd spin around. And then I'd tie it up. Okay? So, not going to do that, just to keep moving along with things. But so remember I said before I did this that I already prepped the patient. So there are some people that will wait till they're gowned and gloved to prep the patient. And so you may need, and that's totally reasonable, just as long as the patient gets prepped appropriately. You may need to give them those ChloraPrep at this point, so you might have to hand something onto the field. In my situation, I like to do this before I get all gowned and gloved because it gives it time to really dry. The drape is underneath the kit. This is a mistake that we'll see younger residents make, is that they open this kit up. If I open this kit up and unfold it, the drape underneath is no longer sterile technically because the edges of the pieces of drape inside the kit may have touched outside the area and it's no longer sterile. So make sure that if you see them going to open this kit that you remind them, don't you want to drape first? And you do. Standard drape, this is the drape we use in the OR. This is the same drape that the nurses from the vascular access team use. There's a right side and a left side. The right side has writing on it. The left side doesn't. And it shows you which side the head goes to. So I'm going to take this and basically look at that fenestration. I'm going to look at the patient where I know that I'm going to go. And I'm going to watch that fenestration go right down onto the patient. As I do this, I'm going to be very careful not to put my fingers outside this drape area. Almost all drapes open away from you first. They're meant to fold away like that and then fold towards you. This particular drape, I know the third layer down has some Velcro on it. So I'm going to find that Velcro, put my hand right on the area that I just put the fenestration down. I'm going to bring the drape up over the patient's head, making sure that I don't, get unsterile doing stuff, and sometimes I have to have my helper go around and fix that up for me. Then I'm going to do the lower portion of the drape. In this situation, the right way to do this draping is to lift the drape up and away from you. You don't want to go too much out like this because you're more likely to hit something. So we're going to go like this. And somebody's going to be over there to get that bottom edge. So if you grab that bottom edge on the, move it away, you've essentially draped this whole patient out. So this whole bed is sterile. Make sense? Now I'm going to get my kit ready. So I'm going to come over here, bring my kit and my table so that it's to the level that I want. If I have the drape appropriately set up, I can grab the edge of the table and move it around. I can lift it up and down. But make sure that you don't see somebody grab down here or reach down below their waist. That's not the right thing to do. You want to keep it at your waist or above.
Do you use eye protection too?
I would normally wear eye protection, we just didn't get that out. Not everybody wants to do that, but everybody should do that. It's the best practice. Okay? Can I have those flushes? I like to grab them as opposed to having them drop onto the field, mostly because they can fall off the field if somebody drops them on there. They're just round. Inside the packaging, and this is where it's important to know what's inside the packaging, what you need to get extra and what you don't. This foam is just packaging. I use it as a little buffer to raise the tray up out of the way. And then I start to address items that are inside the kit as I see them. And I start to arrange them in a way so that I know what I need is in the order that I need it. I like to move from left to right. 4x4s I'm going to use. I'm going to get my wire ready. The wire has two pieces on it. There's a introducer portion and there's a guard portion. The guard portion is not necessary at all. It's just to protect it inside the packaging. So I like to throw that off the field. Then I'm going to make sure that the wire moves freely in and out by using my thumb to do that. I'm going to load it up so that the curve is out of it. Set that off to the side. This is the SorbaView dressing. That's the standard dressing that we use. That's what's in the kits. That's what's in the central line dressing change kits. It's a SorbaView. And that's something that I'm going to use at the end. So I like to set that off to the side, out of my way on the right-hand side. There's 2 syringes inside the kit. That's all that you should need for this procedure. They're identical. They're the same syringes. They're 5 ml syringes. And what I'm going to do first, when I see the syringes, what my mind's going to is I need to get my lidocaine ready. So best practice is that you'll use a filter needle to draw up lidocaine that comes out of glass. There's a filter needle inside the kit. That's the needle that the operator, whoever's doing the procedure, should use to draw this up. So I'm going to get that, attach it to my syringe, make sure my plunger's working. I grab a 4x4, cover the glass end, make sure I'm not pointing towards anybody. I'm going to pop that. And if I can get that off the field, I want to get it off the field. I've just got to throw a bucket over here. But I'm never going to drop that down below my waist to put something in the garbage. That's a bad maneuver. Okay, so in this, I'm going to draw up my lidocaine. I'm going to use one of the, there's 2 needle holders inside this kit so that I can set the needle down so I'm not recapping. There is a label inside the kit that says lidocaine 1%, 10 mLs per ml. It doesn't make sense. It says 10 mls per milliliter. It's not exactly correct, but basically anytime you inject a medicine into a person, it has to have a label on it. It used to be that we didn't do this at all. We just draw lidocaine in the same syringe we draw saline or anything else. But now, if the Joint Commission were to come in on a, or CMS were to come in on an inspection, walk into the room while we're doing this, and that syringe is not labeled, technically we're out of compliance and we could get fined for that. There's 2 needles to do the numbing with. There's a fine gauge, 30 gauge needle. I don't like to use that, so I tend to set that off in the field. This is a 25 or 27. That's what I like to use for my numbing, so I'm going to set that down there like that. The next syringe I'm going to get set up is my, this is my syringe I'm going to use to get into the vessel. There's 2 needles that come in the kit. One is a single, I think this is an 18 gauge needle. The wire can go right through the center of this needle. The other is an angiocath, and you'll see people use this more frequently with an IJ. This has a catheter over the outside of the needle. You can't pass the wire through the needle. You can only pass it through the catheter. Okay? The important distinction there is if I use this, because this doesn't accept a wire through it, it's a smaller gauge, it's not considered a pass. You've seen people do finders. They keep looking for the needle, especially if they're using ultrasound. They'll put the probe down and then they'll keep going like this. Because this doesn't accept a wire, and you'll see that definition in PRISM, any needle that accepts a wire, forward movement through the skin, subcutaneous tissues, whether it enters the vessel or not, is considered a pass. With this needle, if I'm using this one, every time I move forward with it, it's considered a pass. I'll talk about that more in a minute. But I typically find that people only use these when they're doing either an IJ or it's a really, really sick patient, because you can't often get into the vessel easily, so I'll use that. in that situation. Next, I'm going to get my catheter, because that's just what I see next. There are these stopcocks that come on here that are the old needle type, where you put the needle through the end. I like to get rid of those, get them out of my vision so I can't see them because they're just clouding what I'm going to do. Inside of the kit are spring-loaded valves, claves like we call them. And I'm going to put the claves on each of the ports. I'm going to take a flush and I'm going to flush each of the ports. We use arrow catheters. Arrow catheters typically have the white port is the furthest out and the brown port is the furthest in, and then the other colors are in between there. That's pretty much standard. They're also labeled on the actual catheter itself. It tells you, I'm sure you guys have looked at that before when you're putting medicine in, which channel you're going to use. The distal port is the brown one on most arrow catheters. What I'm going to do with this, because this is where my wire is going to come through, I'm going to make sure that fluid comes out of it. I'm actually going to take the old style stopcock, apply that, and take the clave and the flush off in one piece, because at the step that I need that, it'll be there. It'll be ready to go. Set that down. And then the rest of the stuff I really don't need till the end, so I'm just going to leave it there for right now. If I can, I try to throw things into the garbage. I'm going to turn back to the patient now because I'm pretty much ready to start my procedure, and this is where I like to do another timeout. I like to say, okay, Mr. Smith, right subclavian. We're going to do a triple lumen 7 French, 20 centimeter line. You good with that? Everybody okay? There's another piece of reference right here. Get that out of the way. And then I like to do is I like to set up things in the order that I'm going to use them up on the field. So I know that I'm going to first numb the area. Once I've numbed the area, I'm going to get into the vessel. You guys can come closer if you want to. I'm going to numb up the area, I'm going to get into the vessel, and then I'm going to wire the vessel. I like to put those 3 things up there. That's just how I keep track of where I am in steps, and I don't want to have to turn to get to those. I'm right-handed, so having the table right here close to me is the way I normally do things, but lefties sometimes will do it opposite. Just depends. What you don't want to do is have the person's, if their back is next to their table and they hit the table, it's not sterile anymore. You got to make sure that you let them know that. So it's good to offer the suggestion. You sure you want your table like that? Maybe if you turned it around, you won't hit it with your back when you're doing stuff. So just, that's a good thing to do. The technique of doing this, just so you know, some people will actually make a mark on the skin before they prep and everything. I don't like to do that because I've seen people get so focused on that mark, either it's a pen mark or it's actually a break in the skin, and they keep going for that and keep going for that even though it's in the wrong spot. They put it in the wrong spot to begin with. I like to use my anatomy to figure out where I'm going to go. So the way I do that is, with my left index finger, I'm going to find the sternal notch, which is at the end of the clavicle. Everybody's got one. I'm going to put it right in there. With my thumb, I'm going to reach my thumb out as far as I can go. I'm going to try to reach their AC joint. Most of the time, if you try it on yourself, you put either your thumb or your index finger in your notch. You can use your other finger to touch your AC joint. The landmarks for this are, I'm never going to, if we divide the clavicle up into thirds, I'm never going to go on that most lateral third. Always going to stay away from that. So I find the distance, I move my thumb to the edge of the middle third, and I leave it there, because now I know that I never want to put my needle outside of that. Make sense? The next thing I like to do is I like to make sure that I've exposed an area enough that I can numb this person once, either using, I don't have to go back and numb them at the end when I go to sew the line in. So what I'll do is I'll use that landmark, I'll come just a little bit inferior to that. I'm going to get into the skin and I'm going to make a big wheel in the skin. And on this mannequin, if I make a big wheel, it just destroys the material. But you can imagine that I'm going to make a wheel at least this big, preferably this big, just in the skin. I'm not going beneath the skin, I'm staying in the dermis. Once I've done that, I'm going to move to the area where I'm going to actually put the needle in. Because the hub is going to be more lateral than where my insertion site is. Does that make sense? So I'm not going to want to just have it numbed right where the insertion site is. I want it numbed where the hub is going to be sewn in, and those things have different locations. So I tend to take my needle out. I'm going to bring it more medial on the patient, beneath the clavicle. I'm going to go into the skin. I'm going to aim for the clavicle. I'm going to hit the clavicle. I'm going to pull back on my plunger to make sure that I don't have any blood getting in there. I'm going to pull back ever so slightly, and I'm going to inject along the periosteum, so right on the bone itself. I want to get that area nice and numb. The fewer lines you've done, the more likely it is that you'll use the clavicle as a landmark to hit with your needle and then go beneath it. As you get more and more comfortable, I rarely do that anymore when I do a line. I almost always just, I know how to get beneath the clavicle in one shot, and that's how I do it. But we teach any of the learners to hit the clavicle and numb that first. You'll see that on the list too. As I withdraw the needle, then I'll numb that track that I've made. Without looking, I can almost always get over here and put that needle away so it's off my field. So I've numbed that whole area like I told you. I'm going to find my the needle that I'm going to use to get into the vessel, make sure the plunger is working, find the bevel of the needle. In this case, there's only two positions it can be in, and they're 180 degrees from each other. Sometimes it lines up with the numbers and sometimes it doesn't. But that's what you'll see people looking for, is finding where that is. I've never let my index finger leave that notch because that's sort of a target for me. I'm going to go just beneath the clavicle, or inferior to the clavicle, about a finger breadth, a little bit more proximal than where or a little bit more medial than where I started my numbing. And I'm going to aim with the bevel up right for my index finger. And as I do that, I usually will feel a little giving way, and then I'll see the blood come into the syringe. I'm going to take my fingers and I'm going to rest them carefully on the patient so that I don't let the syringe move up and down or side to side. Get my wire right there. I'm going to disconnect this and be ready to put the wire in very quickly. If the patient's bleeding a lot, or if it looks like there's air being sucked into the catheter or into the needle, I want to cover that with the end of my finger so we don't cause an air embolus. Once I get the wire to go in, I'm going to ask you to look at the monitor and make sure if you see any ectopy, you let me know. Good. The wire is 62 centimeters long. How far is it from where I enter to the superior vena cava right atrium junction? Does anybody know? On an average adult, it's about 14 to 17 centimeters. And this wire actually has marks on it that tell me where I am. The next thing that I do, I like to teach people, is be very careful when you take this out of its sheath. You don't just let it go and hang down, because almost always it'll want to hang down beneath your waist. So I hold on to it with my left hand, set the sheath back up here because I don't need it anymore. I'm now going to take the needle out, and just making sure I never let go of the wire. The wire is always in my hand. I like to hold it with my left hand, kind of like this. I'm going to put this needle back in here. Then I'm going to put up the next things that I need. I need to make an incision. I'm going to dilate. I'm going to put the catheter in. And I need a flush. So I typically leave my flush over here. Some people will put it up there. But I'm going to never let go of this wire. Take the 11 blade. I'm going to make a stab incision into the dermis. And then I tend to check the wire to make sure that it's in that stab incision. If it's not, you can make a beautiful stab into the skin. But if the catheter isn't going to go through that hole, it doesn't do you any good. I tend to resheath this and put it back up here because I don't want it on my field anymore. I'm going to take the dilator and feed it on here. Again, I never let go of the wire. I'm a righty, so I like to hold the wire in my left hand and do everything with my right hand. This is a 7 French catheter, and I probably don't need to dilate the vessel in this person. So what I don't need to do is push this thing all the way in. If I was doing like an 11.5 dialysis catheter, I need to dilate the vessel, and I'm going to probably push the dilator all the way in. In this situation, the only thing I'm trying to do with this is dilate the subcutaneous tract, so that when the catheter goes in, it's not getting hung up on anything. So I'm going to grab the dilator. I'm going to go in about as far as I need to. I tend to have a habit from just doing trachs that I do it 3 times just to have it. Key thing that's important that you can sort of know about, if you think of this thing as a train, anything that goes over the wire is a train and the wire is a track. If you think about trains, if the train and the track move together, you're going to crash. So the train and the track should never move together. What will happen is you'll bend the wire and it'll go into the wrong place. So doing this and sort of checking is one of the things that you can do. At this point, the patient might be bleeding quite a bit, so what I'll do, that's why I keep my 4x4s over here, is I put some 4x4s over that so that I'm not making a big mess. I'm going to take my catheter, I'm going to load it up. Again, never letting go of the wire. So I know that I have a hold of the wire with my left hand and it's hitting the hub here, this lock that I put on. If I do this right, I can actually hold the wire, hold the catheter, and pop the wire out through the hub so that my fingers can grab it and I can let go with my left hand. Okay, I've never let go of the wire the whole time. Really important step. Again, something that when an operator is doing this and they get nervous, it's an easy thing to forget, like let go of the wire because I want to get something over here. It's important for you guys to remind people not to do that. Now I'm going to advance the catheter over the wire. Again, same deal. I should never have the train and the track moving together. If I do, I'll end up with a big bent wire. This mannequin tends to stick, and you shouldn't normally see people put this much force to put a line in. There's marks on the lines that tell you how deep it's going. I already bent this thing a little bit, so it's not really going in. There we go. Just like the wire has marks on it, the catheter has marks too. And as I'm doing this, make sure that you guys are watching the monitor for me, paying attention to how the patient's doing. I'm going to go into about 15 just in general. On most patients, that's about the right amount. Once I know I'm in the right spot, I'm going to take the wire out. Holding the wire and the catheter in my left hand, I'm going to grab this flush and the clave that I had before. I'm going to keep that. I basically call this palming. I palm it in my right hand. I start to take the wire out. If it's taking this much effort to get a wire out, there's a problem. But on this mannequin, it tends to stick in the rubber, so you'll see when it comes out, it's all nasty. Should never take this much. If a wire comes out looking like that, there's a problem. It tends to come out every time on these mannequins, on these training mannequins like that. So the next step is, minute I get that wire out, I want to connect this back up to my hub so I don't let air go back into there. If it's going to be a delay, this is an important place where you can be watching. If they don't have everything ready, they want to put their finger over the tip so they don't let air get tracked back into there. I tend to keep that in my hand so I can just quickly put it on there. Now that's the distal port. I'm then going to draw back and make sure that I get some return of blood into here. You can't really see it. It's kind of a purplish color, but there's some coming out of there. Once I get the blood in there, I'm going to flush until it's clear. And do the same thing on the other ports. Pull back, flush, disconnect. Pull back, flush, disconnect. So now I've got my line in. I'm ready to start securing it. The steps to secure it, what I tend to do is I get the bio patch out. Also, I'll leave my left hand up there all the time to hold the catheter so it doesn't drop down to my waist. I get the bio patch out. That's the first thing that I put on there because it's hard to estimate where to sew it if you don't have the bio patch set up already. Okay? There's a two-part connector that attaches this line. There's a white part that's a soft silastic. That goes on the line first. It should be as close to but not on top of the bio patch. If it's too far away, the line is much more likely to pull out. If it's too close, if it's over the bio patch, then you really can't get the next bio patch on when you go to do a dressing change. So it's got to be that sort of middle ground. This blue part slips over the top of that and holds the silastic in place. So again, I'm still holding this in place. I'm going to get my sutures out. Right now we still have suture in the kits. There's a trial of what are called stat lock devices that we're going to be using in both the units and in the OR to try not to suture these in. But right now this is what we have in the kits. So I'm going to get my suture out. And I'm going to sew. Best practice is to do what's called an air knot. What that involves is I take a bite of skin and I leave a loop so that it's not real tight to the skin. Tie a knot and then tie the knot to the hub. By doing that, it's less likely to break down the skin, less likely to cause infection. There's some newer studies that show that. So in the heat of the moment, most people will just throw a couple of knots in there, but that's not best practice. It's okay to ask, how come you didn't throw that air knot that I learned about? You can ask them that. Just wondering. So in that situation, basically I'm going to sew this in by doing the air knot first. Upstairs, Dr. Allen tends to teach people to use the dilator as a guide for how much space should be in that knot. So he hasn't put the dilator down like that. So if you see them bringing the dilator back up onto the field, that's why. So I'm going to tie it tightly around the dilator. Then I'm going to take my needle and go through the hub. Then I'm going to tie knot to knot. So the hub is not directly attached to the skin, it's attached to the knot. Does that make sense to everybody? You can all come and look at this when we're done. The only cutting device that's available in these kits is my scalpel blade. So I'm going to use that to cut, leave a tail, set that back down. I'm not going to sew the other side just because it really damages these dummies. Take my gap device out, and you can see that there's a little space there. It's not too tight. Now I'm ready to put my dressing on. So I'm going to get my sorbet out. The drapes that come in the kits make this a little bit difficult. The kit, the window is about this big. But you can see that this dressing is a lot bigger than the window. So we have to find a way to do this. There's two ways to do it. One way is to now cover this up and carefully take the drape off. Get my ChloraPrep out, re-prep the area, and then put the dressing on. Just because in the operating room that really wouldn't work out so well, my habit is to not do it that way. I tend to lift up the drape with my fingers like this and carefully rip this plastic area. I don't want my fingers to go underneath there, but it's okay for me to rip this stuff. Remember I prepped so widely at the beginning? I was telling you how big of a screen or big of an area that I would do. It's partly because of this. Got to make sure that in the window, I see the
Re-prep again?
I don't need to do that if I haven't taken the whole drape off. If I've prepped widely enough and I don't move, I don't break sterile here, it's okay to do it this way because the window on the Zorba View fits inside that fenestration okay. So the objective here would be to get this down. And if I get that sorbet view set up so that the frame of the sorbet view is in contact with the skin, the area of the dressing that's sterile remains sterile, and now I can start to mess with the drape. Does that make sense? That when you look at the sorbet view, it's just basically a piece of telfa that makes a frame. Once that's down and secured, I can start to move this drape around a little bit more because the contact point is sterile. And then I want to do my interlocking device. Again, start this, and then I just move the drape, get it all secured up there. Okay? All right, so now I'm going to start to clean up a little bit. First thing I'm going to do is hold on to the line while I pull the drape back. Okay? And I'll get that in a minute, but what I've done this before where I pulled the drape back, caught the hub here, and ripped the line right out even though it was sewn in. I've done that once, and I've seen other people do it, but essentially this is ready to go. There's several things that I need to do though. It's my responsibility to take care of the sharps that are in the kit. The other thing that I want to do is date and time this. Well, I don't have a pen with me right now, but I like to ask, would you mind dating and timing that for me? So, you know, now it's time to readdress your patient if you want to. So you can come around and do that. I'm going to start getting my my sharps out of the way. And this is where we start to say, hey, how'd everything go? Did I mess anything up?
I think so.
Yeah, did I make any mistakes? You would have said something though, right?
Yeah.
Yeah. Good.
Do we have to change?
Patient was in
things?
Trendelenburg, right?
Nope.
You didn't say that.
What's that?
Yeah,
Your patient was in Trendelenburg, right?
Yeah.
You didn't say that.
When I set up the patient, yeah.
Should
So-
we change these claves right away since you drew black the blood into them? Or it's okay.
It was done in a sterile fashion, so you shouldn't have to, but when you do the dressing change, you probably should change it.
She's
What's the
thinking
policy
like
on that?
Whenever
I
you
thought
draw
anytime we
blood
do
is
blood.
what she's
But you may
thinking.
be doing lots of multiple, and ICU is a little
Okay.
different, and we can have some sidebar discussions about
Oh.
that after.
The other things that I need to do is order a film to check placement of this line. And just like other times in the unit, you'll often do is you'll have called radiology ahead of time because you see that I'm just about done, just like we do in other situations. That's perfectly reasonable. Or check with the clerk and find out if they're on their way. I need to complete my documentation in Prism. So we can show you what Prism looks like, and we'll put some clips on the video. Is there anything that you can see that I forgot? Anybody got anything? Anything I messed up? No? So I'm going to take care of all my stuff here in a minute, but anything else, Susan, you want to get on the video?
No, because I think what we'll do is we'll end the session now,
Okay.
and then we'll talk about some
Okay.
PRISM, and then do some questions and discussions.
Great.
And then what I'll do is I can bullet those.
Okay. Good.
So, thank you, Peter.